forward. Coming across, showing up for you guys as recording. Yeah. So we're going to start out this morning with Amy giving us a brief update about the biggest change in vaccines, which is really around children, and then we'll shift to Isaac on therapeutics. So Amy.
Morning, everyone. I just wanted to tee things up that we are anticipating that there may be approval for COVID-19 vaccines for children under the age of 5 coming up in the next few weeks. The FDA meeting is on the 15th, it's scheduled. And I'm not sure when the ACIP meeting is, but there is one on the books for the 23rd and 24th, although this is not on their agenda currently. But it is possible that we could see approval for the initial 2-dose of vaccines for COVID-19 for the younger kids sometime at the end of this month. And so we wanted partners to start to think about what it's going to take to deliver vaccines to this age group. I suspect, as with the kids from 5 to 11, that there will be some time that's going to need to take to roll out the vaccines, get the supply in the state. It comes in on an allocated basis and get the supply up in the state, but we are starting to really think about that, and we would like our partners to think about that as well as to how this will roll out for the young children, because I know it takes a little while to get this prepped up at the health system and the practice level. I'll turn it back to you, Lisa.
Okay, any questions about that before we shift gears? Dora.
Yeah, sorry, I can't, I'm on a phone, so I can't tell. I raise my hand very easily. Do we know if it's going to be a different, coming in a different vial, a different formulation completely? I know it's a smaller dose, but I don't know if it's a, we're just going to say, oh, take the 5 to 11 dose and, and make it smaller, or if it's going to come in as separate vials, because that's one thing that holds things up a little bit in terms of us getting ready, because we have to put it into a new, if it's a new drug, basically, we have to put that in the computers a lot differently. And then the second question I have is, do we know whether it's 2 doses, 3 weeks apart, or 3 doses, or how many weeks apart? Do we have any idea of the dosing that they've applied for? Thank you.
Dora, I don't know those answers yet, although I'm thinking that it is a different vial, but I'll check to see if we can get some more information. I just haven't seen it. I know as much as you do about what's in the news about it. I think that they're applying for the initial 2 doses 3 weeks apart, but then they're also studying whether or not a 3rd dose is going to be needed. So I think that these are all details that we are kind of waiting to hear more about at the FDA meeting coming up next week.
And the other thing, since I have my microphone still on, we have a cadre of volunteer vaccinators who've been unbelievable throughout the whole time, but very few of them are comfortable with this age group. So we are planning on putting on, some trainings, but any videos or anything you guys can get a hold of or have, I haven't have a chance to do a web search, but it just seems like there's got to be some videos out there on 2 things. One is, vaccinating in this administering the vaccine in this young age group, when you give it in the thigh, where in the thigh, when do you decide to give it in the arm, that kind of thing. And then also calming techniques for the various age ranges within that range. Because as you know, between 6 months and 5 years of age, there's a lot of developmental stages. So any resources on those would be really great. Because I know the trainings that we might put on, it takes quite a bit of effort to put those into video. And so it'd be nice if somebody else has done that, to send those around. And then also the, pediatricians and the parents are, groups of them are saying, well, gee, we just want to go to the pediatric office and have it done there. And the pediatricians are like, yeah, we'd rather just vaccinate in our office at this age group. But I think that's great. And I'm concerned that like with every other age group we've expanded to, there is a tsunami of, an absolute tsunami of demand. And even if it's only 30% of parents who want their kids that age vaccinated, they all want them vaccinated in the first 10 days of the vaccine being approved. So as we know, there's a tsunami of demand and then it precipitously drops. So we are trying to plan some public clinics in our service area, in addition to our practices, providing vaccine to their patients in the office setting. and hopefully during some evenings and weekends as well. So I just put that out there that I think there's a lot of people who want to just do it in the office. And I think that that's great, but I think we need some availability for the public as well, and at mass clinic times as well. Thanks.
Amy,
Thanks,
any
Dora.
comments? We'll move on to Isaac here.
Yeah, Dora, I'll look and see what we can find. And thanks for bringing up these issues. Thank you.
Thank you. Thank you.
Thanks, Dora. Amy, I don't know whether AAP has any general resources for vaccinating in this age group. I mean, I think we just have to remember that, yes, this is the first time that we're giving COVID vaccines to this age group, but it's hardly the first time that we're giving a vaccine to this age group. And, I think a lot of the, basic logistics in terms of, administration are going to be the same. It's just that we're bringing in a lot of potentially providers who aren't as familiar with vaccinating this age group. So.
Yep, and the Maine Immunizations Program has done trainings in the past on childhood vaccines, and I think that they have materials that are available. So.
All right, turn to you, Isaac.
Great. Thanks, Lisa. Hi, everyone. Isaac Benowitz, State Epi at Maine CDC over here. I wanted to make sure that we spend some time this morning talking about all these therapeutics available for outpatients with COVID. I know that this will be familiar material to some of you on the line, but also see some names and faces on the line that I don't get to talk to as often. There's just a lot that's new in the therapeutic landscape, and really sort of looking across the state and across the country, I'm just very concerned that these drugs aren't getting used for enough people who are eligible for them, and that there are a lot of missed opportunities to prevent hospitalizations and deaths. And so I'm going to go ahead and share a few slides to walk through this. But I also just wanted to mention at the outset that this call has been a monthly call on Tuesdays at 7:30. We're going to be shifting that, at least for the next several weeks, to a weekly call on Friday mornings at 7:30. It's a more sustainable time for us, and it will provide us with the opportunity to have a more regular check-in with either sort of the same crew or with a rotating group of faces from around the state who are really interested in knowing what the latest is around therapeutics and having questions answered, as well as updates on vaccines. So I'll put that new information on the Friday morning 7:30 call into the chat in a moment. I'll also be sending it out in a health alert today or tomorrow, but just wanted to make sure that I got that message across for anyone who has to drop off before the end of the call. So with that, let me go ahead and put up some slides. All right. Lisa, can you give me a thumbs up that you can see that? Great, thanks. So just briefly, here's the big picture of where we are with COVID prevention and therapy. And I'm really going to focus on the first half of this slide. And so for people who are not sick, we have vaccines, but we also have pre-exposure prophylaxis, particularly or specifically for people with moderate to severe immunocompromised. And I'll talk a little bit more about Evusheld a little bit later in this talk. Most of what I want to talk about are the monoclonal antibodies. At this point, we just have one remaining monoclonal antibody. Apologies, there's some older information on this slide with some of the older monoclonals that we've taken off of the market at the moment because they don't work for the Omicron variant. And then we have these two new oral antivirals that have just come into availability under FDA emergency use authorization in the last 5 or 6 weeks, Paxlovid and Molnupiravir, as well as Remdesivir, which we've been using for inpatients for a while now, but is now FDA approved for outpatients. And I'll say a bit more about that in a moment. So this is really the big picture of where we are with COVID treatments for outpatients. Remdesivir and sotrovimab are IV medications, and Paxlovid and Molnupiravir are the oral drugs. I just want to highlight a few things. The first is that Remdesivir, sotrovimab, and Paxlovid have pretty comparable effectiveness in preventing hospitalization and death. They're all in the 85 to 90 or 85 to 88% effectiveness range. Molnupiravir, still an excellent option because it's more available than some of these other drugs, but only 30% effective in preventing hospitalization or death. Both of the oral drugs, Paxlovid and Molnupiravir, are given twice daily for 5 days. And then sotrovimab, the monoclonal, is an IV infusion that's given once. Remdesivir is an IV infusion that's given over 3 days, which is certainly a challenge in the outpatient setting, but one that we're looking to bridge. Remdesivir is really the newest exciting player on this scene, and I just want to make sure that I spend some time talking about this for those who haven't been part of this conversation. So the Pine Tree study, which is in the New England Journal, it's dated January 27th, but it was released online mid to late December, showed an 87% lower risk of hospitalization or death for patients who were treated with Remdesivir IV as an outpatient for 3 days, starting within 7 days of symptom onset. Based on that study, we very quickly saw some institutions start to give Remdesivir essentially off-label for outpatient use, and FDA has moved quite quickly to approve the use of IV Remdesivir for non-hospitalized patients. That the formal FDA approval is for patients who are over 12 years and over 40 kilos, but they've also revised the emergency use authorization to include treatment of pediatric patients down to 3.5 kilos. So this is something that is really fairly widely available. There are no supply shortages. There are logistics shortages. There are also concerns around insurance because this is the only COVID therapeutic for outpatients that is not provided free by US government. It's available in some sites around the state that have been providing monoclonals. It is available in some other hospital and clinic sites, or will be soon. I don't have a full list of those. I'm working to build it, but I wanted to put this on the radar, particularly for anyone that is already offering IV monoclonals and is thinking about what else they can do. This is the drug that's in really wide supply, and we'd like to see more of it. This is just a brief review of where we are with monoclonals. So again, sotrovimab is the only monoclonal that's currently still on the market. It can be used for adults and children over 12. It's not authorized for post-exposure prophylaxis. The other two monoclonals that we had before, Bam-Edi and Regencov, have been paused, and FDA is in the process of revoking both of those emergency use authorizations, to the best of my knowledge, because those drugs do not work for the Omicron variant. A few other things to highlight about these two oral antivirals that we have right now. So Paxlovid, really excellent drug, but in very short supply. So, very good effectiveness against hospitalization or death, very short supply. We're getting about 360 treatment courses every 2 weeks. So just not a lot that we have at our disposal right now. It's also notable for having several drug-drug interactions. And so there is dose adjustment needed for renal impairment. There are restrictions on giving it with patients with severe liver disease. And I'll say a little bit more about that in a moment. Molnupiravir, not as effective, but still an excellent treatment choice. Much better supply. We're getting about 1,400 courses into the state every 2 weeks. And so this is simply something that we can make available to more people. There's a strong warning against use in pregnancy because of concerns around toxicity and mutagenicity. It can be used in pregnancy, but it is certainly not the preferable option, and other drugs should be offered first. If it is used in pregnancy, it should be with extensive and explicit counseling around the concerns. So just a little bit more about Paxlovid. It's a combination of two drugs, nirmatrelvir and ritonavir. The other thing that I wanted to highlight about Paxlovid, and you'll hear me say this for several of these drugs. So Paxlovid is only available under FDA emergency use authorization, and I highlight that that is different from full FDA approval. This is, sort of a preliminary form of approval that FDA can move to do much faster. The practical implication is that it really needs to be prescribed under the EUA terms, which is treatment of mild to moderate COVID disease in someone who is high risk for progression to severe COVID-19. I can say a little bit more about what all of those variables mean, but what it comes down to is that this really should only be prescribed in patients who have risk factors or are in an age group where there's concern for progression to hospitalization and death. off-label prescribing is something that I've been hearing about a little bit and really is not appropriate for drugs available under EUA. And the main other thing that I wanted to highlight about Molnupiravir is that it's not authorized for patients less than 18 years of age. So the other 3 treatment options that we have right now are available down to 12, and in the case of Remdesivir under EUA down to really 1-year-olds or so, well, newborns, but Molnupiravir is only for adults. A little bit of information here on the renal dosing for Paxlovid. And so just we have some sort of guidelines also available from NIH and from FDA related to how to change the number of tablets that are used based on clearance. I just want to highlight a few tools, and this is pulling from the ASPR playbook. And so these are all resources that are available on the COVID-19 website for the U.S. Assistant Secretary for Preparedness and Response. So this is just a provider checklist that I find quite helpful for Paxlovid. In particular, it calls out the renal dosing as well as just flagging the concerns around drug-drug interaction and hepatic disease. Also, because Paxlovid as well as Molnupiravir are supposed to be used only starting within the first 5 days of illness, there's a recommendation to actually put a note on the prescription stating to please fill a prescription by a certain date, and that ensures that it's only used under the EUA criteria. That's certainly challenging, but if a patient is farther out, then we do have other options. Remdesivir can be used within 7 days of symptom onset, and sotrovimab within 10. I'll just mention that there is a fairly long list of contraindications. These are mostly drugs that interact with CYP3A. This information is also in the ASPR playbook. There's a similar provider checklist that you can find from ASPR for Molnupiravir. This one, some of the key things that this highlights are the appropriate counseling around women who are pregnant or have childbearing potential. And there's also notably a note in there for men of reproductive potential, that there's a recommendation to use a reliable method of contraception correctly and consistently during treatment and for at least 3 months after the last dose. I just wanted to highlight that because I know that a lot of the attention is on pregnancy, but this is not, there are considerations for men of childbearing potential as well. Just a few other things that I'm going to flip past a little faster, but just want to highlight that there is all this extensive information about Paxlovid and Molnupiravir prescribing from ASPR. I can share some links to that in a moment. This is a somewhat complex diagram that you may have seen from ASPR as well. This just walks through essentially patient eligibility for Paxlovid, Molnupiravir, sotrovimab, and Remdesivir. I find this quite helpful. Takes a moment to wrap your head around it, but it is, I think, helpful to just walk through which patients are eligible for each of those drugs. I want to take a moment, though, to talk a little bit about how we're recommending that clinicians approach use of these 4 drugs, given the resource limitations that we have. So this diagram here is really helpful, but what it misses is which of these drugs are in very limited supply and how we optimize the system to ensure that we can essentially treat the most patients who come in with different risk factors and have different levels of risk while ensuring that we're doing the most to prevent hospitalization and death. And so what we're recommending is that Remdesivir be essentially the drug of choice for most patients who are eligible for several of these drugs. Remdesivir is, as I mentioned, it has some hurdles around insurance and transportation because it's covered by insurance and because it's an IV infusion given over 3 days. However, it is in abundant supply. and it is the only one of these drugs that is in abundant supply. Remdesivir has comparable effectiveness to Paxlovid and sotrovimab, and really, to me, every time we can give remdesivir to a patient, it's a win, because it means that we can hold on to those very, very limited supplies of Paxlovid and sotrovimab a little longer for some other patient who might not be a good candidate for remdesivir. So I'm recommending remdesivir first, followed by Paxlovid. Paxlovid can be used for patients who are presenting within 5 days of illness, and it's a great choice. We just don't have a lot of it. Sotrovimab would be my third line recommendation. Again, excellent drug choice, available up to 10 days out from symptom onset and just given as a single infusion. It is in very short supply. We're getting around 120 doses per week, which means we can treat about not even 500 people across the entire state in a month. That's really just, it's like tiny little bits of that we're getting. So excellent choice. If we had, a lot of it, then I'd say Paxlovid and sotrovimab for everyone, but I am concerned that there are patients who may not be great candidates for remdesivir, and the more remdesivir we can give out, the more we can hold back that Paxlovid and sotrovimab a little longer. And then molnupiravir, again, still a really valuable addition to this armamentarium because it's an oral drug and because it can be used in many patients, and it is more widely available than Paxlovid and sotrovimab. To accomplish those goals of ensuring that we can essentially hold the Paxlovid and sotrovimab for as many patients as we can who wouldn't be eligible or good candidates for the other drugs, we've developed these eligibility tiers for the state of Maine. And these are based on recent data for hospitalizations and deaths, and essentially place groups that are at the highest risk for hospitalization and death highest up. And so our tier 1 are patients who are unvaccinated, 50 plus, and have one or more clinical risk factors. Patients who are vaccinated, 65 plus, and have clinical risk factors. Anyone with moderate to severe immunocompromise, whether vaccinated or unvaccinated. Additional groups that would be eligible for remdesivir and molnupiravir. Broadly, we're saying that those who meet eligibility criteria for the drugs but are not in tier 1 would still have access to remdesivir and molnupiravir. But we've sort of laid out this tier system to be flexible so that we can continue to watch the available supply of the drugs and the COVID case rates and hospitalization and death rates in the state to continue making tweaks to these tiers to ensure access for the most largest numbers of high-risk patients. I also just want to highlight that we've specifically called out people living in congregate living settings, which includes nursing homes, assisted living, jails, prisons, and homeless shelters as being in our second tier. That's something that I think is notably missing from some of the national recommendations. And then I just want to briefly highlight where all of these treatments are available. So Paxlovid and molnupiravir are currently at a handful of retail pharmacy locations of Walmart and Hannaford. They're also available or will be available at 2 FQHCs, PCHC and HealthReach. Monoclonals are available at several infusion sites across the state, and remdesivir is largely available at hospitals, but will be available at more hospitals and at clinics. I'm glad that we have all of these options in the state, but it is a fairly fragmented system. For a patient to get treated, they need to first see a clinician, and before that, they need to get a test. These things are happening in a large number of places. So people are getting tested at pharmacies or hospitals or clinics or at home, then going somewhere else to see a provider and get a prescription or a referral, and then going to a pharmacy or a hospital or a clinic. And it's just a real challenge. And we've heard about that from a number of places and a number of different angles. What we're moving to at the moment, and really this week and next week, is a shift towards what we're calling outpatient assessment and treatment sites, or one-stop shops for short. This represents an opportunity to provide streamlined coordinated care where a patient could go to one site or one coordinated set of sites to get tested, assessed, and treated with any of the available treatment options, reflecting some of the recommendations that I made a moment ago in terms of who would be eligible for each of these and the order in which they would be offered. And then I just wanted to take a moment to talk about pre-exposure prophylaxis. So Evusheld is a long-acting antibody combination. It's only for use in adults and pediatric patients who have compromised immune systems. We're receiving a very limited supply right now. We're getting about 600 doses per month. And so the initial focus is treating the highest risk patients. We're currently distributing it through 5 clinical centers across the state that are also accepting outside referrals. I'm just going to go through this briefly. I did send out a health alert yesterday evening, and so there's a lot more information in there that gets into a little bit more detail for the types of patients to consider prioritizing and how we've approached that here in Maine. I will just give you a very brief snapshot of what our current eligibility criteria look like. So these are specific to Evusheld distribution. Really categories. So categories 1 and 2 are the folks who are currently eligible. This is largely patients with malignancies on treatment and patients with transplant on treatment. There are a number of congenital immunodeficiency syndromes in here as well. So we're working through 5 centers to increase access to this drug. And then as we make our way through that group and as supply improves, eligibility will hopefully expand to a much broader group of patients that are immunosuppressed due to medical treatment, and then the small number of people who are not able to get COVID vaccine because of a history of severe allergic or other adverse reaction. So, and then I'll also just highlight that we've sent out a few HANs in recent weeks, January 3rd and 7th, with broad information on therapeutics. Missing from this slide is the health alert that I sent out yesterday evening on Evusheld pre-exposure prophylaxis. And then just some really great resources to highlight. There's just a ton of information from NIH and from ASPR. I'm going to break there to make sure that we have time for a few questions, and I'm going to put into the chat the information on the new meeting series. So again, this will be transitioning from a Tuesday morning monthly call to a weekly call on Fridays at 7:30 a.m.
And so there was a question about that, Isaac. So this call for clinicians will continue, but it's moving from Tuesdays to Fridays, but it is separate from the call that you've got with a group of clinical pharmacists and advisors, essentially. So if folks have been on that one, this is a separate one. And there we go, the Zoom info. So we'll discontinue this meeting invite and transition it to that one. But we won't start this Friday, but next. No, you've got it started.
We will start this Friday.
Oh,
yeah.
We will start this Friday. Okay, sorry.
Yeah.
And then somebody also asked me directly about sharing the slides. We typically do post these slides and the recording to the Maine CDC website. So if you want to send me those, Isaac, I can do it for this time unless.
Great.
Yeah. All right, we are at the hour. Any other questions before we go?
Cheryl, go ahead.
Thanks. Can you just comment a little bit about what the data source is for the prioritization of outpatient therapies? Because it is significantly different than the most current NIH prioritization guidelines. And it, for example, would put a vaccinated, healthy 25-year-old pregnant woman ahead in line for therapy over like a 65-year-old unvaccinated person, or like a 45-year-old unvaccinated obese diabetic. And those are the groups that we're seeing actually, take up hospital beds for severe COVID.
Yeah, so I pulled together the data on all of our cases, hospitalizations, and deaths from October, November, and December of 2021. And then looked within, so I split those out by vaccination status, by age group, and by whether or not they were identified as having one or more medical comorbidity. And then I looked within each of those groups at the rates of hospitalization and the rates of death. And so the groups that are highest up are the groups that had high rates of hospitalization or death. There's certainly space in there for, when you have broader clinical knowledge about who you deem to be at high risk for hospitalization or death, I would encourage you to still treat those people similarly. But as you know, the data are sometimes a bit coarse and can't address all of those nuances. So I think we've talked about this fairly extensively internally and feel that it's a really helpful step beyond what NIH has broadly said nationally. I've actually struggled to find a data source for NIH's recommendations. So thanks.
So just one follow-up question. So are you saying that if we did opt to give the very high risk unvaccinated person in their 40s therapy over, the healthy, younger, uncomplicated pregnancy, that would be, what would be the implications of that?
Sorry, just walk through that comparison again.
I guess the thing that makes me most uncomfortable as a treating clinician is that I think there is quite a bit of data that identifies sort of unvaccinated people less than age 50 to 65 who have really serious risk factors for severe disease being really higher risk than a lot of other, say, vaccinated people in their 60s or, younger vaccinated people who are pregnant. I'm just, as a prescriber, it would make me uncomfortable making that choice. And, if we made a different assessment, is that unacceptable?
I'm fine with you making your own independent assessment of who should be eligible. These are really intended to lay out what we see as patterns in the state. And, I think that the scenario that you laid out is totally reasonable in terms of who you deem appropriate for therapy. Yeah, I don't think that we're ever going to have all of those nuances in our patient eligibility criteria. So, does that sort of give enough information?
Yeah,
Or is there...
Thank you.
Thanks. Other questions? I know we're a few minutes over.
Yeah, and I do need to go, Isaac, on another one. I think if I stop, we'll stay, but I do need to end.
You can transfer it to me and I can stay on for a moment or two.
There we go.
Great, got it.
Thanks.
Thanks, Lisa.
Thanks.
All right, any last